ORBITA trial has generated a huge amount of controversy. It's everybody walking up and down the hallways here is still talking about it, and it was presented at TCT, published in The Lancet 2 weeks ago. It has also generated an incredible amount of media response, which I think is out of all proportion to the importance of the trial. So as you know, the ORBITA trial was the first trial of PCI in stable angina in sham-operated patients, sham procedure patients, which is important. I mean, we learned from the renal denervation trials about the importance of placebo.
ORBITA studied a very stable, healthy patient population in whom there was chest pain, a angiographic stenosis, and that patient was referred for elective percutaneous coronary intervention. So in that patient population, I think the placebo effect, absolutely, there is some placebo effect that might have worn off beyond 6 weeks, which we do not have results of. As you know, ORBITA had a 6-week evaluation of the primary endpoint, which actually was not chest pain, it was duration of exercise. And most importantly is the power of the study for these endpoints that everyone is generalizing. This study is not powered for those important endpoints. And even the change in exercise time, the power of the study is questionable, because the 30-second assumption of improvement between the two therapies sits right in the middle of the confidence interval. So we were not powered to show that difference.
The criticisms of this very good study are that it was underpowered. No, it was powered for quality of life. You can do quality of life in, they probably could have done this in 100. I'm glad they did it in 200, but as a continuous variable, quality of life clearly can be done in sample sizes. It was short term. Well, that's when the patients say they feel better, is right after the procedure. So to criticize it on that grounds, I think, is also unfounded.
I would have loved to have actually had patients who would absolutely benefit in a study like this, because there were patients who did not have baseline ischemia at the time of randomization who were also received PCI, so they wouldn't benefit. So it's difficult to evaluate.
There are many who say that they would have never sent a patient like this to the cath lab with mild angina. They would have never done a stent on somebody like this with 60% disease that was potentially FFR negative, for example. And my response to some of those individuals would be that I think when you look at the practice patterns in the United States, that is probably not altogether true. Certainly at our hospital, other hospitals, people can, our use of FFR, for example, in the country is really low, and there are a lot of patients who, I think when you look at those angiograms, those patients would go to the cath lab and they would get a stent in most cath labs in the United States.
One of the things that interests me about this trial is that ORBITA clearly shows that PCI reduces ischemia. That raises a lot of interesting questions. One of them, and the major one for me, is, okay, ischemia is reduced, and in 6 weeks, we're never going to see the outcome of that reduction in ischemia. But long run, is reduction in ischemia good or not? We really don't know the answer to that. The ischemia trial, which is coming on, may or may not give us some insight into that answer. But the short version of what we should do with this is we need to understand a lot more about the outcomes of myocardial ischemia, what it really means to reduce it, how much we need to reduce it, and whether or not in the long run this really makes a difference so that we can substantiate doing PCI in this relatively small population of patients with single vessel disease.
What I think the interventional community is failing to grasp is data back from the 1980s and 90s, some of which was ours, regarding silent ischemia. And when we were doing all of that ambulatory monitoring, most chest pain that patients have in the setting of obstructive CAD actually is not ischemia. And conversely, there's a lot of ischemia out there that is silent.
I think, and many people think, that it's time to turn our focus to the microvasculature, the lesions and the vessels that are too small to see on conventional coronary angiography. And I think the fact that When somebody has a stent and they no longer have an obstruction in their coronaries, but they continue to have angina, suggests that they have disease in the microvasculature, that obviously putting in a stent in the large vessel doesn't help.
These patients were exercising a good duration. In fact, their stress test, they exercise for a long period of time. So at 30 seconds above that, it's a question, right? I mean, you know. And remember, I think it is really important that the vast majority of our PCI populations are not these patients. The vast majority are patients with multivessel disease, acute coronary syndromes, where we have already, in acute coronary syndromes, we have shown an important benefit.
The adage that we're doing this to improve their quality of life and relieve their angina, I think no longer can be defended. And I commend the National Health System in the UK for doing this very important trial. We've estimated that probably half of the PCIs that are being done in the United States, and I'm going to guess it was similar in the UK, are being done electively for, quote, angina quality of life. And this speaks directly to that being a pretty poor investment.
Patients quite often who present with angina are very anxious and come to us and want an intervention. And we really need to push back a little bit and discuss with patients the option of guideline-directed medical therapy, and that really we have good evidence that it's safe, effective, and it may be every bit as effective in relief of symptoms as is PCI.
I was impressed with a couple of things about this study. The first one was that in that 6-week lead-in when they intensified anti-ischemic therapy, there were a substantial number of patients whose angina went away when a third anti-ischemic drug was added. So at the very least, this trial tells us that in a patient who's relatively stable, and where the decision about, well, maybe I should have an intervention or not, adding a third anti-ischemic drug and letting it have a chance to take hold is a very reasonable thing to do. And if the main goal here is quality of life, taking a pill every day for many patients is certainly more desirable than going through a procedure which then involves long-term dual antiplatelet therapy, et cetera.
If you look at the type of intensive medical therapy that these patients got, it was very intensive. It got, they were home blood pressure monitors were given to these patients. They had communication with an on-call cardiologist frequently as 2 to 3 times in a given week. And for many of us in practice, that type of intensification of medical therapy is not feasible.
I don't believe that based on the immediate study available and the duration of follow-up and the size of the study that we're quite yet necessarily prepared to make wholesale changes in our guidelines. On the other hand, it really needs to make us rethink how we approach this problem.
I think the idea that all care is personalized and should be the individual physician working with that individual patient and saying, well, heck, you know, the guidelines don't really apply to you because you have X, Y, or Z. I think that's always a legitimate argument. That's what we do going to work every day, is to try to do good personalized care. But we need to look at all the evidence. And when a patient of moderate to high risk, not super high risk, is sitting in our office, we need to think about this study and ask ourselves whether or not that might be relevant to this patient. It's a little bit like C-sections. Women have been coached, and other women just like it. They want to know exactly the day that they're going to have the baby. And yet we have buckets of information about why C-sections are bad for mother and baby and result in some of the unacceptably high morbidity and mortality rates that we have in the United States, the most developed country in the world compared to essentially all other countries because of our high C-section rate. So the question is elective PCI. That's probably something that, again, is contributing not only to healthcare costs, but I think unacceptable morbidity and some mortality. And we need to wake up and smell the coffee here.
I think ORBITA raises so many issues with people who are interventionalists that we tend to just jump in and think of all the bad things that ORBITA has done, all the negative parts of it, the bad way it was designed, et cetera, et cetera. But I think it's important to point out that there are really positive things and important outcomes here that we can't just simply brush under the rug.